I'm talking about the true term is pulmonary arteriovenous malformations. And a very closely related condition called the PA-LA communication. So I'm going to show you some examples of this extremely rare condition, which is 2 to 3 per 100,000 population, mostly congenital, rarely acquired in the context of liver disease. Mainly, the congenital can be sporadic or associated with hereditary hemorrhagic telangiectasia where it is diffuse. Otherwise, it's solitary or multiple. Commonly involves lower lobes, especially left lower lobe. It's often asymptomatic despite fairly significant cyanosis in some of these patients. There is dyspnea on exertion in those patients, but generally it tends to be, if it's small, it's often not so significant until there is a neurologic episode. In fact, one of the commonest reasons they present is from brain abscess and a host of neurological symptoms. Rarely you have hemoptysis. You can suspect it clinically, but it's very difficult to pick it up clinically. You have a cyanosis with a normal echocardiogram that tells you that that could be a possibility, and you can do a contrast echo to confirm the possibility of this condition. Typically, after 3 cycles, you see it. A chest X-ray is very useful, actually, because it's abnormal in the majority, and especially useful in solitary or discrete fistula malformations. And of course, you can do a host of imaging. In fact, in the beginning, in the early era, I used to just diagnose it and take the patient to the cath lab and try and close it. But now we prefer to do a CT to get a better roadmap. So this is a chest X-ray. For example, you can see in this particular example, this is the first case I remember having closed nearly 20 years ago, a very large pulmonary AV malformation that had recurred after surgery and produced a brain abscess. This is the diffuse sort, which really you can't close in the cath lab, but you need to look elsewhere. And if you look at, often some of these patients have Abernethy malformations, which then can be closed in the cath lab, and these patients can get a whole lot better. This is a recent publication of ours where we published our collective experience with congenital photosystemic shunts, where we've got several examples of these conditions. It used to be a situation where pneumonectomy, lobectomy, etc. used to be done. My first case was a patient whose lobectomy missed the fistula, and the patient was persistently blue. So transcatheter occlusion is absolutely the treatment of choice when it is feasible to close them, when they're a discrete or solitary fistula. It's necessary to do an angiography in as many views as required to identify the fistula, but you have to be absolutely sure of distinguishing the native supply from the fistula supply or the malformation supply. And I have got a trick for this, which I'll share with you guys. So you do an angiography. This is an example of a 26-year-old. But if you use a balloon catheter, it automatically finds its way to the fistula. And you can do a balloon occlusion angiography, and you see this in 2 views where you can easily identify the feeding vessels. In this particular example, it's quite straightforward. But here, once you get that, you put you get into a very distal position with your sheath, and then you put in a vascular plug of appropriate size, or even coils. It still has a role, especially when you have numerous pulmonary AV malformations. You need to have coils because it will become very expensive. And then you should try and do a complete job. Sometimes you need to do it in 2 or 3 sittings. And I have one example where I needed 3 sittings. I'll show you. And then you must be very meticulous, because you need to try and eliminate, because you will leave behind a substrate for brain abscess. So here is an example of a patient, and I described this technique quite some time ago in this publication, which Shiva and Kannan are all co-authors of. And you can see, basically, this is a case which is very interesting. An infant who was referred to me by a pediatrician after the cardiologist insisted that this patient does not have heart disease. They said, I can't explain the cyanosis. And this X-ray was abnormal. So this child was actually very blue, 55%, because the entire cardiac pulmonary blood flow was being sucked into this malformation. So the technique is very interesting, which we sort of devised here. We take a balloon catheter through a long sheath. We put in a long sheath and take a balloon catheter. Typically, a Berman catheter is a good idea. And that would automatically find its way into the fistula, because that area has the maximum pulmonary blood flow. Once it finds its way into the fistula, it will occlude the fistula. So now you inject, you will not see the fistula. And then all you need to do is to advance your sheath, which has already been placed. And once you advance your sheath, you can actually demonstrate the malformation. And you're absolutely at the site where you'd like to put your whatever you want to put. In this particular case, this was before the era of plugs. I took multiple coils with bioptome, and this patient had a very good result. And on table, very gratifying, 95% as soon as the fistula was closed. You confirm that, you make sure that there are no fistulas in other parts of the lung, and that usually allows you to be fairly sure, and then you can. So this is another example. More recently, we've kind of, for the bigger fistulous communication, bigger feeding vessels, we tend to use occlusive devices. So here is an example of an adult patient who had a brain abscess, where you wasn't particularly desaturated, 92%, but he had a brain abscess, and you can see this particular feeding vessel. You need to be inside that vessel. But then once you put your guide wire, and you can often get the guide wire out from the venous end of this, all you need to do is to advance a guiding catheter. In this particular case, I've used a 8 French guiding catheter. And once I've got the guiding catheter, I use the Konar device because it's uniquely suited for, because of its low profile. You can insert it through a guiding catheter. And all you need to do then is to be inside the fistula, but you can pull it back and make sure that you've got it well plugged into the vessel that is feeding. So that usually completely closes the fistula, and the patient almost instantly shows an improved saturation. They're often multiple. This is my most challenging case thus far. This child who was actually saturating at 60% and unexplained cyanosis had numerous pulmonary AV malformations. So I took 3 sittings and 24 or 25 coils and devices of various kinds to actually occlude all of this. But this was 10 years ago, and the girl has done supremely well. Even now comes with good saturation. So very gratifying, but it did take a lot of effort to actually get rid of all of these fistulas. But there isn't any other option in these kind of situations. A closely related condition is PA-LA communication, which is a discrete communication between the proximal pulmonary artery and the atrium. This is the first case, I think, of transcatheter closure that was ever reported, that we reported long, long ago. And again, Shiva and Edwin are authors of this paper. Until then, surgery was what was thought of, but it was quite easy. In this particular case, this child had an ASD. So we went through the ASD and created a wire loop across the fistula. And then all we did was to take a PDA device and close it. And again, on our way out, we closed the ASD as well. So this was a very, very gratifying case, but much more challenging was this particular example that I did in another institution, where we had a 26 very large communication and an intensely desaturated 17-year-old, where we used where the communication was between LPA and the LA, which is extremely rare and doesn't have a great. I'm not sure about the embryologic basis of that particular lesion. Anyway, we managed to close it, and again, this can be done quite easily in the cath lab. Another example that I did, again, a PA-LA communication that we used. This has been published recently. So essentially, it's a rare cause of cyanosis. You have diffuse variety with portopulmonary syndrome, a small fraction of which have Abernethy malformations that can be closed in the cath lab as well sometimes. But when they are discrete, when they are, having identifiable feeding vessels that are approachable and in reasonable number, we can actually do it all in the cath lab. Needs a meticulous approach, but the results are very rewarding. Thank you.